Hello, everyone. This is Dr. Madhusudan Rao on the program I teach medical students. Today in our class, we are going to talk briefly about the most common poisoning, that is iron toxicity. Iron toxicity happens to be one of the common poisonings, as iron preparations are commonly prescribed to many patients with different conditions associated with anemia, out of which the antenatal women are the commonly prescribed for anemias. And the children, when the capsules are kept within the reach of the children, they consume these products, that is the adult preparations, which contain large amount of elemental iron, and ultimately leads to accidental iron toxicity, resulting in the devastating complications leading to death. It's a common accidental poisoning in children, especially under the age of 6 years. When they consume tablets prescribed to adults, as a result, leads to serious consequences and death. Because iron is corrosive as well as cytotoxic. Okay. Well, iron poisoning in adults is considered to be suicidal attempt. Chronic iron toxicity results in the children who undergo regular transfusions for transfusion-related chronic hemolytic anemias, resulting in hemochromatosis and multi-organ damage, which we have done already in a different class, in the topic hemochromatosis. So when the children they consume the large quantity of iron tablets, it is all the most important to proceed with the lab evaluation, early diagnosis, and treatment, which will then early treatment is going to improve the outcome of these children, preventing morbidity and mortality. Coming to the etiology, well, a dose of 20 milligrams per kilo is non-toxic. Okay. 20 to 40 milligrams per kg body weight, it results in moderate degree of toxicity. When consumed more than 60 milligrams per kg body weight, it leads to severe toxic effects. It means 60 milligrams per kg body weight amounts to 10 times the regular doses given to children. It is all the most important for the clinician to know the elemental iron content of the iron preparations in order to understand the quantity of the iron that is consumed by the patient. So ferrous sulfate salt contains 20 milligrams percent of the elemental iron. Ferrous fumarate is 33 milligrams percent. Ferrous gluconate is 12 milligrams percent. Out of which ferrous sulfate is the most commonly prescribed drug. Well, what is the pathophysiology? Iron, as I told you, is a corrosive. It has a corrosive effect, resulting in the mucosal damage, ulcerations, and bleeding. Cytotoxic. Ferrous part of the iron is toxic to the cells. It can directly penetrate the cell membrane without any carrier protein and cause the damage to the mitochondria. Damage to the mitochondria results in the metabolic disturbance, uncoupling of the oxidative phosphorylation, release of free radicals, ultimately resulting in the cellular damage and organ dysfunction. In acute poisoning, let us say, there is severe abdominal pain secondary to the corrosive effect of the drug and the gastric mucosa, which results in the nausea, vomiting, and sometimes hematemesis. Excessive loss of fluid leads to circulatory failure. At the same time, cardiac dysfunction adds to the cardiogenic shock. Intestinal ulcerations, thereby leading to perforation, results in peritonitis and septic shock. Well, when the patient comes out of all these complications, healing of the intestinal ulcers results in scar formation and ultimately results in the intestinal obstruction. Well, it is hepatotoxic, there is hepatic necrosis, and fulminant hepatocellular failure. Cardiac toxicity results in the cardiac dysfunction and cardiogenic shock. Injury to the nerve cells results in the seizures, and the patient may present in coma. Let us touch on the toxicokinetics of iron. Iron absorption is complete 2 to 4 hours after the ingestion. Okay. Only 10% of the ingested iron is absorbed because iron absorption is what we call strictly regulated because of the presence of hepcidin synthesis by liver, which has got the control on the absorption of iron. By inhibiting the transferrin receptors, iron absorption is kept under check by the hepcidin molecule. But when iron is consumed in toxic doses, this intestinal barrier is damaged and there is free absorption of iron into the circulation. Once iron enters the blood by binding to the transferrin, transferrin is the iron binding protein that carries the iron in ferric form in the blood. Ferric form of the iron is non-toxic to the tissues. Okay, it is stored in the liver as ferritin and is used by the hematopoietic cells for regular erythropoiesis. Okay, when the individual consumes large or toxic quantities of iron, there is more quantity of the unbound serum iron. Free plasma iron is in ferrous form and it is toxic to the cells. Okay. When individual consumes large quantity of iron, there is iron saturation is complete. Okay, and the unbound iron is freely circulates in the plasma that results in the tissue damage. Iron intoxication results in a transferrin saturation, and the unbound iron form or free plasma iron, which is in the ferrous form, which I told you, is directly toxic to the tissues. That's what happens. Look at this picture. There are 5 stages that are described in the clinical presentation of the iron toxicity. There is stage 1, where is the GI irritation. Stage 2, it is the recovery from GI symptoms. It is asymptomatic phase, but serum iron levels are high in the stage. Stage 3 is stage of shock and metabolic acidosis. Okay. Stage 4 is the stage of fulminant or progressive hepatocellular failure. Stage 5 is the stage of mucosal healing and intestinal obstruction. So this is in brief the 5 stages of the clinical presentation of iron toxicity. Coming to in detail, clinical presentation is described in 5 stages. The patient may present at any stage of the iron toxicity. That's why clinician should know time of consumption of the iron by the patient. If he presents within 5 to 6 hours, that is stage 1, he may be having abdominal pain, nausea, vomiting, hematemesis, bloody diarrhea, or diarrhea without blood. Okay, these are the symptoms of stage 1, which may be present between half an hour to 6 hours after taking the iron. Between 6 to 12 hours, individual is asymptomatic, but serum iron levels are high. This is the sort of, we can say, the honeymoon phase of the iron toxicity. Then patient may progressively go into the reappearance of the abdominal symptoms, develop features of shock, either due to fluid loss or due to cardiac dysfunction, develop metabolic acidosis, coagulopathy with bleeding tendencies, multi-organ dysfunction, and death, unless treated otherwise. Between 12 to 36 hours, this is the stage 4. There is elevation of the hepatic enzymes and progressive hepatocellular failure, ultimately ending in fulminant hepatic failure. If he recovers from this stage, okay, patient is sent to the hospital, discharged from the hospital, and advised for follow-up. Okay, as a late manifestations, between 2 to 8 weeks after consumption of the iron, he may be presenting with features of intestinal obstruction, either duodenal obstruction or small bowel obstruction. This is the spectrum of clinical manifestations of iron toxicity. Coming to evaluation. Well, go about serum iron levels estimation 4 to 6 hours after ingestion. Then, if serum levels are less than 300 micrograms per deciliter, it is said to be mild toxicity. If the serum iron levels are between 300 to 500 micrograms per deciliter, it is said to be moderate. And if the patient is having more than 500 micrograms per deciliter of iron, it is associated with severe toxicity. You can predict the patient is going into serious complications. Ask for serum electrolytes to assess the effect of fluid loss and the renal injury. In order to correct the fluid and electrolyte balance, you should check the serum electrolytes as a part of the clinical evaluation. Do the liver function test, go for renal function test, take the X-ray abdomen if the patient has consumed the tablets within 4 hours. And go for total binding iron capacity and percentage of iron saturation. This photo shows the X-ray of the abdomen of the patient, showing the radio-opaque shadows in the stomach, probably iron tablets. Then what is the line of treatment? Gastric bypass. If the patient has presented within 4 hours of the poisoning, do the gastric bypass carefully, not to damage the gastric mucosa. You can go for a whole bowel irrigation with polyethylene glycol. If there are signs of coagulation dysfunction, administer vitamin K and FFP after going for the PT and the INR, and give the IV fluids and FFPs in order to correct the shock. And patient needs ICU care because he needs regular monitoring under the follow-up, and steps of the treatment has to be modified depending upon the clinical status. And iron chelation has to be done with deferoxamine. Well, once the patient has recovered the treatment, you have to counsel the parents and advise follow-up in order to look for the late consequences of iron toxicity. This picture shows iron body. I like to pump iron, he says. Maybe too much of iron in my body. Do I need chelation? Of course, we need chelation. If the patient has presented in a symptomatic stage, it is around 4 to 6 hours after ingestion of the iron. He needs to be observed carefully. Okay, you cannot just say that patient is all right. You don't require treatment. So proceed with the investigations, and if serum iron levels are more than 350 mics per deciliter in an asymptomatic patient, 4 to 6 hours after ingestion, admit them. He is the likely patient surprisingly going into severe manifestations of shock. That patient who is asymptomatic after following 4 to 6 hours of following poisoning, and if his serum levels are more than 350 micrograms per deciliter of iron, admit the patient in ICU, monitor the condition, and treat effectively. Okay. Well, then when do you discharge? The criteria to discharge are serum iron levels must be less than 300 mics per deciliter, and he must be asymptomatic. Okay. He is asymptomatic during the process of observation for 4 to 6 hours, and he is hemodynamically stable. Then discharge. Okay. At the same time, advice follow in order to look for the late complications like intestinal obstruction. So, well, if the patient is not treated, what happens? Of course, there is hepatic injury leading to liver necrosis and fulminant hepatocellular damage. There is a myocardial injury resulting in myocardial dysfunction and cardiogenic shock. He may go into seizures, nerve cell injury, leading to coma. There could be intestinal perforation in acute stage, resulting in perforation, peritonitis, septic shock, and late consequences of intestinal obstruction. See, an iron tablets, iron that is going to save your life because you are administered iron preparations for anemia. Okay, a life-saving drug is going to cause the death when taken in toxic doses. Well, this picture shows the organs that are affected by iron toxicity in chronic iron poisoning, that is hemochromatosis. Iron metabolism. So everybody knows about it. You take the iron and the iron that is absorbed in the intestines in the form of it is converted into from ferric state to the ferrous state. From there it is absorbed and bound to the transferrin. Transferrin converts the ferrous iron to ferric form, and bound to the transferrin, it is carried to the blood. Okay, it is most of the time it is utilized by for erythropoiesis, and any excess of iron is stored in the liver as ferritin. Okay, when the serum levels of iron is high and there is saturation of the iron binding capacity, or iron binding protein is saturated with iron, free plasma iron is toxic, and it is resulting in damage to the cells and organ dysfunction. This is how the iron metabolism goes on. Iron is put in by the oral administration of iron. At the same time, iron is added to the body by the regular lysis of the RBC. And iron, that is the heme part of the hemoglobin, is taken up by the transferrin to the erythropoietic tissues for reuse of iron in the erythropoiesis. Okay, that's how the iron metabolism goes on. As such, there is no mechanism with which iron can be eliminated from the body. Okay, so there is a check in iron absorption is strongly controlled by a system, that is the hepcidin molecule, which is synthesized by the liver. They have a check and the absorption of iron at the intestinal level. So that's how the iron is so important to correct the anemias of the patients, and it should not be consumed in excess doses, because poisoning of the iron is going to result in devastating complications leading to death of the patient. Well, thank you very much for patient listening, and we'll meet you again in the next class. And my dear students, please remember that iron, once administered to the adults, the tablets must be strictly kept away from the reach of children, so as to avoid the iron poisoning and the serious consequences that results in the iron poisoning. Thank you very much once again. We'll meet you again in the next class. Until that time, bye-bye.